Today we'll be discussing about secretory otitis media or otitis media with effusion or blue ear. What is otitis media with effusion? From the name itself, otitis media. So middle ear is affected. It is the accumulation of fluid or mucus in the middle ear or sometimes in the mastoid air cell system also. What causes otitis media with effusion? You know that the middle ear is aerated by the Eustachian tube. So the first pathology is due to some Eustachian tube obstruction whereby the middle ear cannot be aerated. The Eustachian tube and the anterior mesotuberculum are lined by ciliated pseudostratified columnar respiratory epithelium. The mucosa contains both goblet cells and mucus secreting glands. Any inflammation of the epithelium triggering increased production of the mucus and increased number of goblet cells can result in otitis media with effusion. When you see the histopathology, in an established otitis media with effusion, the middle ear mucosa can be replaced by thicker pseudostratified mucus secreting epithelium with various degrees of specialization. The flat cuboidal mucosa of the entire middle ear will be replaced. And there can be dysfunction in the cilia also. The cilia helps pushing the secretion into the Eustachian tube and whereby getting rid of the secretion. When the cilia is malfunctioning also, the secretion will start accumulating in the middle ear. What is the etiology? It is most commonly seen in children. Adults also can develop otitis media with effusion, but generally otitis media with effusion is a disease of the children. The most common causes are the diseases that cause Eustachian tube dysfunction, like adenoid hypertrophy, which obstructs the Eustachian tube. Nowadays, it is said that more than the adenoid hypertrophy, there are biofilms. Those are specialized type of bacterial accumulations that are present on the adenoid, which causes inflammation and blockage of the Eustachian tube. Biofilms are communities of sessile bacteria. These are resistant to disruption. And these have low metabolic rate, and these are embedded in a matrix of extracellular polymeric substance that are secreted by them itself. These communities may adhere to a foreign body or a mucosal surface when the host defense is impaired. So it is said that there are biofilms in the middle ear and also in the adenoids that causes Eustachian tube dysfunction and in turn middle ear effusion. Biofilms can develop as a secondary bacterial effect following a viral upper respiratory infection or an ear infection. Also sinusitis and nasal polyps or chronic rhinitis that causes blockage of the Eustachian tube can cause middle ear effusions. Another etiology is allergy. As an allergic response, there can be hyperplasia of the goblet cells and increased secretions are produced and causes otitis media with effusion. In children with allergy, there can be also be associated urticaria, eczema, asthmatic tendencies. Another abnormality is craniofacial abnormalities like cleft palate. Even after repair of the cleft palate, the child may develop otitis media with effusion because there is deficiency of the action of the muscles. The palatine muscles controlling the Eustachian tube opening are deficient, and the decussation of the fibers are deficient in a cleft palate child. Also in syndromes like Down syndrome, there is more chance of developing otitis media with effusion. In adults, you have to think about any nasopharyngeal tumors other than adenoids causing the obstruction like CA nasopharynx, any meningioma of the skull base compressing on the Eustachian tube opening, causing Eustachian tube obstruction and otitis media with effusion. In barotrauma, like when you are descending or ascending flight travel, can cause changes in the pressure inside the middle ear, causing otitis media with effusion. Other causes are any previous infections of the ear, like an SOM, which gets resolved partially and continues as an otitis media with effusion. And also viral infections, like previous viral infections, that can trigger a bacterial biofilm formation and also can cause secondary bacterial infections which can persist as otitis media with effusion. Another etiology is gastroesophageal reflux. So the reflux can get into the ear and the pepsinogen can cause damage to the middle ear mucosa. Also, this pepsinogen immunoreactivity in adenoid tissue is also reported in post-adenoid tissue biopsy specimens. There are also genetic factors in play, genetic predisposition that affects the aeration of the middle ear, the oxygen diffusion of the middle ear. If genetically the child or the adult is predisposed to developing allergy, there can be more chance of developing otitis media with effusion. Another thing is exposure to pollutants and also smoking, passive smoking, parental smoking in children. All this can predispose to development of otitis media with effusion. Some miscellaneous causes for otitis media with effusion One is like post radiotherapy to the skull base. There can be otitis media with effusion. Also, prolonged intubation, prolonged endotracheal intubation for other surgeries can cause otitis media with effusion in the patient. Another thing is any skull base defect causing CSF photoria gets accumulated in the middle ear can be misunderstood for a otitis media with effusion. So you have to keep all these miscellaneous problems in mind when you evaluate a patient. What are the characteristics of the middle ear effusion? Middle ear effusion, if you take and study, it is mostly composed of allergic mucin, that is glycoprotein mucin. It also contains secretory IgA, that is immunoglobulin A, lysosine, interleukins, and other inflammatory molecules. Also, if you study the microbiology, the most common organisms causing are Streptococcus pneumoniae, Moraxella catarrhalis, and Haemophilus influenzae. So detected in patients with 2 to 3 months duration of otitis media with effusion. If it is not detected in a normal culture sensitivity, you will have to go for a PCR test to detect the organisms. But in children or adults with more than 6 months of otitis media with effusion, no organisms are usually detected. That is why it is also known as sterile otitis media, because organisms are not detected by usual culture sensitivity technique. What are the clinical presentation? The most common clinical presentation will be ear block sensation or hearing loss. Some children or parents may not understand the severity of the hearing loss, and the child will go in for developing speech delay, difficulty in concentration, poor performance in school, poor group activities. All this can be a variety of complaints in children with otitis media with effusion. There can also be some earache, vague earache, dull earache, also some crackling or pulsatile sound or tinnitus inside the ear. If it is a child, we have to get a detailed history, whether how was the pregnancy, whether the child was kept in ICU following the delivery, or whether the child has undergone a hearing screening. All this we have to do. And history of recurrent upper respiratory infection, recurrent ear infection, recurrent throat pain, mouth breathing, snoring, all this history we have to take. In adults, we have to take history regarding any nasal bleed, nasal obstruction, any signs of any nasal masses or skull-based tumors, history of previous radiotherapy, history of previous surgery. All this history has to be taken. What are the examination findings? The tympanic membrane will appear dull. The light reflex will be distorted. That's the cone of light will be distorted. And also the color of the tympanic membrane can be gray, dull. You can also see bubbles, and also you can see an air fluid level inside the middle ear via the tympanic membrane. All this can be assessed. In acute suppurative media, there will be marked congestion that won't be there in the serous otitis media. We should also do a pneumatic otoscopy. The mobility of the tympanic membrane will be affected and the mobility will be restricted. The tympanic membrane can be retracted also. Pars tensa can be retracted. You have to also examine the nose and the throat. Any tonsillar hypertrophy, any adenoid hypertrophy, any nasal polyps, nasal masses, chronic rhinitis, all this has to be assessed. What are the hearing tests that you can do? Tuning for tests can be done. Raynaud's test, Weber's test, absolute bone conduction test. So all this will show a conductive hearing loss. Also, you can do a Pioton audiogram, which will show a conductive hearing loss. Also, tympanometry. Tympanometry, there will be a B curve. In Pioton audiometry, there can be an airborne gap of around 30 to 40 decibel. Sometimes the child can have a sensorineural hearing loss, which can be due to obstruction of the round window, which resolves once the serous otitis media resolves. Also, there can be a 2 kilohertz dip in the bone conduction curve, like a Hart's notch, that also will resolve once we treat the serous otitis media. You can also take a X-ray mastoids or a HRCT temporal bones, which can show the clouding of the mastoids due to the fluid involving the mastoid. Also, and chronic mastoiditis can be identified. What are the complications of the serous otitis media if it is untreated? There can be retraction pockets and attic retraction, which can develop into cholesteatoma. There can be atrophy of the pars tensa, tympanosclerosis, and also in children, speech and language development will be delayed. School performance will be affected. The quality of life will be affected. What is the management? There can be medical and surgical management. Medical management includes nasal decongestion and techniques to open the Eustachian tube so that the fluid will drain by itself. Many recent studies show that many of the drugs that we prescribe now are not so much effective. The drugs we can use is topical nasal decongestants. We can use topical nasal steroids. Antihistamines can be given in allergy. And if you're suspecting an acute infection, you can give antibiotics. Mucolytics can be tried, which will reduce the thickness of the fluid and so that it can drain. Patients can also be advised to try to perform Valsalva maneuver so that the middle ear will be aerated. What are the surgical treatments for serous otitis media? When the medical management is not working and it is not helping completely, and also when the fluid is very thick, that is, it is known as glue. It can be very thick and sticky, which is not draining. In such conditions, we have to go for surgical management of the serous otitis media. The most common surgical management that we do is myringotomy and grommet insertion. That is, we incise the tympanic membrane and insert a ventilation tube or tympanostomy tube so that the fluid can drain through the tube and the SOM can get cleared. Simultaneously, we have to treat the cause that is causing the eustachian tube block. In children, most commonly it will be adenoid. So, an adenoidectomy with myringotomy and grommet incision. Steps of myringotomy I will be explaining in another video. Usually, we do the myringotomy in the antero-inferior quadrant and a grommet or a ventilation tube is inserted. The usual ventilation tubes that we use are Teflon ventilation tubes. Other materials like titanium and also silver and gold coated ventilation tubes are available, which will prevent biofilm formation. We use for short term, we can use Shepherd, Shah, grommet tubes are available. For long duration uses, you can use T tubes. Also treat the surgical cause, adenoidectomy in children, and also if there is any sinus lesions, polyps, chronic rhinosinusitis, all this has to be surgically managed by polypectomy or FES can be done. If a huge tonsil is there, tonsillectomy can also be done. Most studies have shown that adenoidectomy has to be done because it will reduce the duration and recurrence of the serous otitis media. Techniques like myringotomy and just aspiration of the fluid is not shown to be as helpful as a myringotomy and grommet insertion, because once we aspirate the fluid, the myringotomy will close and again the SOM will persist. So it is always better to insert a grommet or a ventilation tube. We use antero-inferior quadrant mainly because there's less chance of a permanent perforation. Posterior quadrant, if you're using, there's chance of ossicular injury. So these are the complications of a grommet insertion. So intraoperative complications of myringotomy and grommet insertions are can be injury to the ossicles, injury to the IS joints, and also if there is a high jugular bulb and you are doing an inferior myringotomy, you can injure the jugular bulb causing profuse bleeding. Another complication is displacement of the grommet into the ear, which you have to find out. What are the post-operative complications? The grommet or the tympanostomy tube is creating a opening from the middle ear to the external ear, so there can be infections. Also, the person with the grommet is not allowed to dive and swim and everything. So, if water goes into the ears, there can be infections. And also, any URTI patient can get an otorrhea or an ear discharge, persistent ear discharge, because the grommet is in situ. Also, there can be blockage of the grommet causing accumulation of fluid in the middle ear. What are the long-term complications are chronic biofilm formation. A biofilm can form on the grommet and there can be infections of the middle ear. There can be affections on the pars tensa, like thinning and collapse of the pars tensa, permanent perforation. That is the one even after the grommet is extruded, the perforation remains. In that patients, we will have to go for a tympanoplasty later. Another complication is tympanosclerosis or meringosclerosis. Meringosclerosis is due to the trauma and the infection. There is hyaline degeneration of the collagen tissue in the fibrous layer of the pars tensa, which is seen otoscopically as white patches. Our main aim is to ventilate the middle ear. Other treatments are also available like mastoid vents, especially in post-radiotherapy patients and all. The grommet will get extruded and there will be fluid accumulation in the ear and the tympanic membrane will be affected. So mastoid vents is directly inserting a ventilation tube into the mastoid so that the TM need not be perforated. So these are titanium implants which attach to the mastoid via osseointegration, and there's a Teflon tube which keeps ventilating the middle ear. Other treatments of eustachian tube dysfunction involve eustachian tuboplasty. It can be balloon dilatation of the eustachian tube and also laser-assisted eustachian tuboplasty, which are recent advances and are being used. Sometimes the patient might require a mastoidectomy so that the mastoid obstruction is cleared. There is low-oblated thick fluids and cholesterol granulomas extra in the mastoid. Mastoidectomy is advised. Summarizing, otitis media with effusion is accumulation of fluid or mucus in the middle ear. Causes are blockage of the eustachian tube. That can be due to multiple causes, like any adenoids, nasopharyngeal masses in adults, any inflammation, infection, allergy, and also increased secretory activity of the middle ear mucosa causing fluid accumulation in the ear. Patient presents with hearing loss, earache, and also some sound in the ear or tinnitus. Diagnosis is by otoscopy. Then you have to go for a photonodiogram and a tympanometry. Treatment is medical management with topical or systemic nasal decongestants, which if not working, we have to go for a surgical management, do a myringotomy and grommet incision and remove the fluid. Also surgically treat the disease that is causing the fluid accumulation like adenoidectomy.